Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. We got Mark and Drew ready to rock and roll here again today as we talk about just some biomechanical variations and really looking at two different ways to assess injury. So starting right off for you guys, a little bit of a prompt question here. In rehab, is poor movement the driver or simply excessive load when we're talking about pain and dysfunction? I'm going to kick it over to Mark to start us off here as I get the timer up and rolling. What you got, Mark?
I think that, the answer is yes to both, but I lean more to the camp of most of the time it is a load intolerance, an excessive load, however you want to phrase it, and less often is it a poor biomechanical issue that's driving the symptoms. Now, there's going to be obviously some variations and some folks that are going to fit more into one category or the other, but in most outpatient physical therapy practices, I would argue that most of the time it's a load intolerance issue.
All right. Obviously, we'll delve a little deeper. Drew, what you think?
Initially, I was thinking yes for both, but I'm actually maybe almost thinking more no for both. Neither is necessarily the driver. And if you go back and when you're specifically thinking about pain, like what causes pain, and it's often the perceived threat. And that can be because of both. So it could be a cause of why the brain is perceiving this threat. Either there's excessive load on something, or it senses, ooh, I don't like this movement, something doesn't feel safe. So yes and no.
Yeah, I can't help but think about when it comes to this question, we're going to be a product of what we've seen in the clinic a lot, right? And in life. And just the first thing that my mind goes to is that many people are going to compensate and trying to come to grips with the fact that if a lot of people have compensated and don't have pain, then those that do have pain isn't necessarily the compensation versus is it something else. And I like, Drew, at least how you're kind of opening up to the idea that it could be a little bit of both. Is it threat perception versus the strict mechanics on it, which is a good way to evaluate. Mark, let's dig a little bit more. So, load intolerance obviously being a little bit more of your direction there. So if load management is a big driver of getting reduction in pain there, do mechanics matter?
Well, I do like Drew's answer because the way that I think about load intolerance is basically we're developing a tolerance to a certain activity or whatever it is, and that involves the nervous system, that involves the communication around it, it involves their beliefs and perceptions around whatever movement pattern it is as well. So I like that, and I would say that do the mechanics matter? Sometimes yes. But in most cases, the lowest hanging fruit in my experience is not fixing somebody's tiny variations in mechanics. If someone squats and has a butt wink, am I going to tell them they can never squat again or they have to reduce their depth until they get rid of that? No. And maybe if they have a low back thing with a lumbar flexion intolerance, and maybe, I modify it short term, but big picture, if they're not competing in powerlifting competitions and all of these things, I'm probably not going to go down that route with them. Whereas if I am working with somebody that needs to be as precise in the movement pattern, you'd think like a sprinter or something like that, then maybe I do go down that rabbit hole, so to speak, as far as the biomechanics of it.
Yeah, I like that. What do you think, Drew?
I agree with Mark, but what was the specific question?
Yeah, specific around do mechanics matter?
Oh, yes. I would say certainly at times, even if you're looking at load and load tolerance, because how much can these tissues tolerate before you get to that perceived threat? There are times when you can change and modify mechanics to calm that down, decrease the nervous system sensitivity so you can suddenly start doing things better, differently. I think of shoulder, changing a position of the scapula, suddenly they have more range of motion. Okay, that might be important to the patient, at least, I think is another key thing of, hey, how can I get back to doing whatever functional thing I need to do? And so if you can change some mechanics and make some pretty quick changes, in my mind, I'm thinking there's probably not a tissue problem. This is more a perception of something. And in that scenario, it's be very important to make some pretty quick functional changes. So when you're getting into the realm of, I think overuse syndromes, we would consider them. Um, can it be more low tolerance versus mechanics? Yeah, I definitely think yes, because there's a ton of people who have terrible mechanics, don't have any pain, no problem whatsoever, and they've probably developed a tolerance to doing whatever they're doing, whether it be tissue tolerance, whether it be nervous system, fear-based stuff. They're like, yeah, no big deal, and it's no longer a threat. But I think there's definitely times where changing mechanics, again, you can maybe offload so that they can continue to do something they love or do it more efficiently. There's a reason why mechanics can be important to that high-level sprinter, because they're more efficient and they're probably doing things slightly different. So if you change it a bit, you can, again, alter the patient's perception of threat, maybe decrease the amount of stress on an area that is sensitive. And that's something I think we can do well. We should be experts in movement, and how can we modify things in order to keep that patient active, keep them moving, keep them healthy, and then as it calms down, work back towards that tissue tolerance and increase it, whether or not they're changing mechanics.
Yeah, I like backing out there in terms of the reality that you think about some acute issues. Plantar fasciitis sometimes can be one, knee pain, some other issues where taping can be valuable, right? Even orthotic can be valuable for short term. The literature showing that in terms of the aspect of just getting out of pain and then building durability after that. And then you get to the point of where, right, what goal are we trying to achieve? Mark has talked about, is it somebody that's a professional sprinter that they have to get every last bit out of what they can do? And so you're really trying to drive and figure out the extra mechanical benefit there. It's interesting, one of the things I talked about that with you guys earlier was just how coaching baseball with anywhere between 5-year-olds to 8-year-olds, 8 to 9-year-olds, just seeing, these kids where, some people are putting a bunch of money into swing coaches. I am not. For some of the kids that are on my son's teams, and it's interesting to see them try to force kids to do certain movements that I don't think they're physically capable to do yet. And so even kind of looking about backing out of, is there times where we let our mechanical lens get in the way of actually treating the patient in front of us and being able to evaluate that too. And so I think assess, don't assume is something I've heard both of you guys say before, which I think is a really good viewpoint as we try to look through this and make sure we're able to hold both of them pretty well. So I think that's up for time. So appreciate the discussion, fellas. Until next time.